morning, everyone. The title of my presentation is The Other Side of Cure, Ciprofloxacin and Corneal Deposits. So introduction for the ciprofloxacin corneal deposits is ciprofloxacin is a widely used fluoroquinolone, which is a second generation fluoroquinolone, which is a broad spectrum antibiotic, and it is widely available in India. The ciprofloxacin corneal deposits have been associated with it, and many reports have been documented. It is relatively uncommon, but they have been particularly documented in patients treated for bacterial keratitis following ocular surgery such as corneal grafting or even LASIK. These deposits typically present as white or yellowish precipitates on the corneal surface. Since the ciprofloxacin is soluble at a pH of 4.5 and the tear film pH is approximately 7.2, it becomes less soluble, leading to the potential precipitation onto the corneal surface. The case that I am presenting is of a 76-year-old one-eyed patient with ulcerative keratitis in the left eye. The patient was PL negative in the right eye and had finger counting of half-meter vision in the left eye. When microbiological corneal sampling with culture and sensitivity was sent, it showed coagulase negative Staph aureus positivity, and the patient was started on ciprofloxacin 0.3% eye drops. When the patient presented 2 weeks on follow-up, corneal deposits were seen in the epithelial defect as seen in the picture, along with corneal infiltrates, stomal necrosis, and corneal neovascularization. Since we had already sent the culture and sensitivity, we could easily switch the patient to another eye drop, which we knew that the patient was sensitive for. So when ciprofloxacin was discontinued and switched to polymyxin B and chloramphenicol, along with atropine and lubricants, patient was kept on close follow-up, and eventually the ulcer healed with leukomatous scarring. Low-dose topical steroids were also later added to decrease the post-ulcerative scarring. Final vision was finger counting at 2.5 meters. No significant visual improvement was there due to the central nature of the corneal opacity. What makes this case unique is that the patient was one eye, therefore the patient had only one functional eye, which made this a high-risk case. The patient showed coagulase negative Staph aureus infection positivity, which is a typically less virulent organism, suggesting that it could be due to host factors such as increased age or compromised ocular surface. The treatment challenge therefore required careful antimicrobial selection and balancing infection control while preventing further toxicity or complications. Ciprofloxacin corneal deposits can be concerning, but they resolve spontaneously on discontinuation. Adjunctive treatments such as lubrication and preservative-free artificial tears may aid in the process. It is important to note that the ciprofloxacin deposit must not be confused with corneal infiltrates, and the likelihood of developing corneal deposits increases in presence of epithelial defects, severe ocular surface disorders, or multiple medications which alter the pH of the ocular surface. So the ulcerative keratitis requires aggressive treatment and management to preserve vision, early recognition of the complication to change the medication so that the patient must be kept on close follow-up, and
thank you, Tulika. I think we have to wind up now. Yes, any comments from the judges? Meanwhile, Coil, will you please be ready with your PPT?
The drug is with
Deepti, Dr. Deepti.
preservative free or with preservative?
So after the corneal deposit, the patient was put on preservative-free eye drops.
Preservative after that.
Yes, because the phosphate experience
Okay.
can also cause.
Harnoor Jot. Yeah,
Thank
please
you,
come.
No, but correct. This can be a question in the exams. Actually, there are so many causes for deposits in the cornea, and fluoroquinolones are, as such, they are known to cause, but ciprofloxacin is the worst. Usually, they recover within a month or two.
Yes,
Okay, with just lubricants, as you said, but there are other causes also of deposits.